Yeah, so the DONIMI study was another study where we wanted to personalize the treatment based on the fact that we saw that patients with a pathologic response have a very good relapse-free survival, and patients without pathologic response have a poor relapse-free survival. But in the DONIMI study, we did not personalize the treatment based on the pathologic response. We already wanted to personalize the neoadjuvant treatments. So therefore, we took one of our biomarkers, interferon-gamma signature, and allocated the patients to different neoadjuvant treatment regimens based on the interferon-gamma signature in their baseline tumor biopsy. So if patients had a high interferon-gamma signature, we wanted to test if they could already achieve a pathologic response with only one checkpoint inhibitor, Nivolumab in this case. And we randomized them between or only Nivolumab for 2 cycles, or Nivolumab and Domatinostat. Domatinostat is an HDAC inhibitor. That was the new compound in the study that we wanted to test for different new treatment combinations. And an HDAC inhibitor, this HDAC inhibitor is known to increase the intratumoral tumor cells and also to increase the interferon-gamma signature. If patient had a low interferon-gamma signature, we wanted to test other treatment combinations and escalation of the treatment. So we randomized these patients in this trial to neoadjuvant Nivolumab plus Domatinostat, or neoadjuvant Ipilimumab, Nivolumab, and Domatinostat. And that triple combination is really the escalation arm. What we found is that all treatment arms were feasible, so that was the primary endpoint of this trial. No surgery was delayed, but we did see that not all patients could get their neoadjuvant treatment schedules, and it was in most cases due to the fact that patients developed a skin rash. This skin rash is thought to be Domatinostat related, because when we gave patients only Nivolumab after they got this skin rash and it was treated, they did not get the skin rash back, whereas patients were retreated with Domatinostat, the skin rash came immediately back again. So because we saw the skin rash, we had to stop the Domatinostat treatment in quite a lot of patients. And we also did not see any improvement in pathologic response rate in patients with a low interferon-gamma signature that were treated with the Domatinostat. What we did see is that the interferon-gamma signature was indeed very good in its ability to predict which patients are able to respond from only one checkpoint inhibitor versus 2 checkpoint inhibitors, because the patients that were allocated in the interferon-gamma high arms all had a pathologic response rate of 80 to 90% with only Nivolumab, with or without Domatinostat.